Good morning and welcome to our January 2019 educational call of the Ohio Hospital Association's statewide sepsis initiative. I'm James Giuliano and I serve as Vice President of Quality Programs here at the Ohio Hospital Association. I'd like to welcome you all here today. Today's program will address the issue of practical education for sepsis care. You know, for years in hospitals, we have conducted mock cardiac arrest codes to prepare ourselves for a very high risk but potentially low volume clinical situation. Sepsis presents a very unique opportunity for readiness of early recognition, and simulation training seems to be one way to address that particular opportunity. Now, joining us on our call today are members of the OHA HIN, the OHA Statewide Sepsis Initiative, the Ohio Department of Health, the Health Services Advisory Group, the New Jersey Hospital Association, the Hospital and Health System Association of Pennsylvania, and Sepsis Alliance. Again, welcome to all of our guests. Please know that you will be given an opportunity to type in questions throughout the presentation using our chat box feature, and questions will be addressed at the end of the presentation. We will be recording this presentation, and afterward it will be posted on our sepsis webpage, which you can visit at ohiohospitals.org/sepsis, and by clicking on the education link once you get there. At that site, you'll find all of our previously recorded sessions that do not contain data. This program has been approved for 1.0 contact hours of continuing nursing education, and there is a link on the screen right now to the electronic evaluation tool. If you wish to claim continuing education, we ask that you log on, complete the evaluation, and in doing so, you'll be requesting your certificate. This evaluation link will be live and open for the next 2 weeks following today's date. If you have any questions whatsoever about this, please contact Dorothy Aldrich, and her email address is listed for you on the screen. As you know, we no longer use a fax submission option. And lastly, I do encourage you to visit our sepsis webpage, and that website has a repository of resources and education, and all of our recordings of our past programs that don't contain data are there. Now, it's my distinct pleasure to welcome Michelle Ricard. Michelle is a clinical educator at Mount Carmel West and Grove City in Columbus, Ohio. Michelle supports the emergency department primarily and has over 10 years of experience in emergency room nursing. She's board certified in emergency room nursing as well. However, she collaborates hospital-wide to include medical staff and several other disciplines to accomplish sepsis care simulation. At this time, Michelle, I'll turn the presentation over to you.
Thank you, Jim. Thank you for having me here today. Hello, everyone, and happy Wednesday, and thank you for taking time out of your day to talk a little sepsis with me. So we're going to take a look at staging sepsis, a theatrical review. So briefly, like Jim mentioned, this simulation came out of Mount Carmel West. I'd like to tell you just a little bit about our hospital there. We're located near downtown Columbus, and we're actually the original hospital in the Mount Carmel Health System. We're a certified primary stroke center, accredited oncology network. We have a bariatric center that we're very proud of, designated as a National Center of Excellence. We're home to several physician residency programs, and we also house the Mount Carmel College of Nursing, which is actually one of the largest baccalaureate nursing programs in the state of Ohio. Soon, Mount Carmel West will be transformed from a full-service hospital into an urban outpatient and educational campus, and we're going to provide most needed healthcare services to our neighboring community. Our emergency department houses 41 beds, and we see approximately 60,000 patients a year. Of course, that number will trend down as we move towards a freestanding emergency department. So in our future state, we're going to function in our same urban area as a freestanding, but with focused resources. So as we're gearing up for this transformational time, we're taking an interdisciplinary approach to focus on education to support our colleagues along this journey: nursing, pharmacy, respiratory therapy, physicians, all aligned. And to bring it back to pediatrics, because that's what I'm going to talk about a little bit today with our simulation, you can see here that pediatrics represent about 1/4 of the population treated in all U.S. hospital emergency departments. And so with that, we developed a pediatric sim for our colleagues to practice in that safe environment, so when the time comes, we're ready for all emergencies. So along with the septic simulation, we also find simulation a great tool to use for adult learners. So I'm just going to briefly give a little history and background on all things with andragogy, which is the theory for adult learning. So a brief look in history. Now, nobody yawn or sign off at this point in time, but being a clinical educator, my data can be a little bit more qualitatively heavy than some of our quality metrics we look at quantitatively. And of course, theories are embedded deep within education. So briefly wanted to review adult learning, since we all are adult learners. No matter what area of expertise we work in, understanding our audiences, whether it's through a meeting that you're presenting at, brief interactions in the hallway, a formal classroom setting, or even to help you cajole your patients with your proposed treatment plan. Understanding how adult learners learn will be keys to your success. So you can see andragogy has been around for over 100 years. German grammar school teacher Alexander Kapp was the first to use the word. It comes from Plato. Andra meaning man, and agogos to mean leader of. And then in 1926, American educator Lindemann wrote extensively on the topic and kind of brought it back to resurface. And probably best known for popularizing the term is Malcolm Knowles, who further developed the humanist learning theory and defined the 6 basic principles of andragogy. So with adult learning and andragogy, there are 6 basic principles to be aware of. The first is that the adult learner, we need to know. We have to know the utility and the value of what we're learning. Just with this presentation, you guys have an understanding. I was going to talk PEDS, sepsis, simulation, but I'm also interjecting how that adult learner learns in all of those environments. When we learn something on our own, we invest considerable energy looking into the benefits and how we're going to gain something from it. Needless to say, we're a little egocentric learners, and that's okay. Next, the adult learner is self-directing and autonomous. Wouldn't you agree? We have a deep psychological need to be seen by others as being capable of this self-direction. The role of the experience is the third principle, showing that adults have prior experiences. We all do, right? It's a rich resource to capitalize on. So here's where simulation, case studies, labs, those group discussions enter for the adult learner. Readiness to learn is certainly dependent on relevancy of the subject for the adult learner. And what healthcare worker isn't affected by sepsis? I think there's quite a bit of relevance for us all. Next, we have to orient the adult learning to real life. As kiddos, we learn more by subject areas, whereas adult learners, we need to be able to problem solve. We have to feel like this knowledge means something to us. It's going to help us perform a task or solve a problem in true real life. Lastly, we have to address the motivation to learn. I found this comical because I was thinking as the new year. It's just like motivation to go to the gym as we embark on many a New Year's resolutions. I say the hardest part is getting there. Once you're there, you don't have a choice. And for the adult learners, our motivation is driven by internal pressure, that desire for self-esteem and goal attainment. We also learn by participation and repetition. So here, being repetitive, a summary of the principles of adult learning. So we learn our best when we want or need to learn something. In a non-life-threatening environment, hooray simulation. When individual learning style needs are met, so we need to tailor and customize to our audience. Previous experience is valued and utilized, that basic first principle that we talked about. When there are opportunities to have control over that learning process. We're not children anymore in that didactic lecture. We want to be involved. We want to have some autonomy. When there's an active cognitive and psychomotor participation in the process, simulation actually appeals to all 3 domains of learning. So the cognitive uses our critical thinking skills. So sepsis, right? Save lives. So think early recognition, using SIRS criteria. And then that psychomotor, that skill-based learning where we perform the actions in the simulation. And when sufficient time is provided so we can assimilate, this appeals to that 3rd domain of learning, that affective domain, to include that human feeling, that time for staff to debrief after the simulation. Simulation overall provides that opportunity to practice and apply what is learned. We also focus on relevant problems and practical applications, reviewing what barriers are present to care for the septic patient. So in essence, for everyone on the call, what's stopping us from that early recognition? What barriers do we have on our front line? And lastly, feedback. Adult learners, we need feedback to assess our progress towards that goal attainment. Enter in our wonderful quality departments and all of the metrics that we review. As human beings, our brain, we always want to simplify work. We want to accomplish this in 3 different performance modes. So in the knowledge-based performance, we're in a new or unfamiliar situation, great space for simulation. We don't have a developed skill necessarily. We're not aware of an established rule to apply. This is where that problem solving, that figuring it out mode kicks into play, AKA along right with adult learning. In that rule-based performance, if-then kind of response, we perceive a situation and our brain scans for a rule. It's usually learned through education or experience, again, adult learning, and we act to apply the rule. It's all about choices. So in other words, thinking, if I see this, then I do that. And hopefully we're going to continue to trend healthcare to where the care of the septic patient is just that. In skill-based performance, a well-developed skill pattern exists in your brain. Those are those knee-jerk type reactions. Our goal with care, and that's our overall goal of care with the septic patient, early recognition and reduced mortality rates. This here was another slide, but I feel like I'm going to be a little bit too repetitive here at this point, but lack of knowledge-based performance. So making sure that when we're in that new or unfamiliar space that we're tapping into our content experts. We're problem solving in a new and unfamiliar situation because we don't always know those rules. And in the real life clinical setting, the best strategy to prevent knowledge-based errors, what do? Stop, right? When you find yourself in this situation, we find an expert source and collaborate. Physicians actually have an excellent strategy for preventing knowledge-based errors. What do? They call for a consult. If the case is complex or beyond that physician's experience or expertise, they do what's best for the patient. They consult with a specialist who knows the rules. This I just wanted to interject in the presentation today. I'm not going to go in a lot of detail, but the study was from 2016 in Jordan, and they looked at the validation of andragogy in practice from an educational setting. It wasn't specific to healthcare, but you can read through this, this will be recorded and released later, that the demographics were younger adult learners. They were 18 to 21, but there were 305 responses, and it showed that applying adult learning principles that we previously discussed truly makes an impact on that adult learner, and the reliability of their tool being used in the study was 0.82. And now before we open the curtain into the simulation, because I know you all are anxiously awaiting, I wanted to take this opportunity to review the acronym TIME if you haven't already seen it. Developed by the charitable organization, the Sepsis Alliance, who's on the call today, founded in 2007, and they also collaborate very intimately with OHA. Dr. Carl Flatley, he founded the Sepsis Alliance after his daughter Erin died unnecessarily of sepsis when she was a mere 23 years old. The Sepsis Alliance is the leading sepsis organization in the U.S. They work in all 50 states. So reviewing the acronym here, you can see that T is for temperature, I for infection, M for mental decline, and E for extremely ill. Easy and brilliant for clinicians and the community alike. And these infographics can easily be found on the website referenced on these slides. As many of you already know, more than 1.7 million people had sepsis. That's 1 person every 20 seconds. Third leading cause of death, as many as 87% of sepsis cases start in the community. So we may need to start focusing our attention to community education in our primary care offices and extended care facilities. That non-present on admission, as also shown in the OHA data. And even more impressive is that 42% of Americans haven't even heard of sepsis. So we as the healthcare community, we got some work to do. So these were some interesting statistics I pulled from the CDC that I wanted to share as we look more at sepsis in pediatrics. Among children, 39% of cases with sepsis occurred before age 1 year. 78% of children had at least one comorbid condition. Cardiovascular disease was the most common comorbidity. We know these kiddos don't often do well. But only 43% of cases of sepsis were related to contact with the healthcare system, 43%. Respiratory tract and GI tract infections were the most common source. Only 62% of children with sepsis had an organism identified on blood culture, and Enterococcus species and Klebsiella species were the most common organisms promoting sepsis, and in-hospital mortality rate among children was 22%. Here I wanted to show you some of our sepsis metrics. Now, while I'm talking about a pediatric sepsis, I want us to highlight the fact that these are our adult sepsis metrics. Recently, our sepsis coordinator presented our mortality rates over the past 3 years. You can see here on the top line that as a multi-state system, we're floating around 17 to 18% for our mortality rate over the past 3 years. Drilling down a little deeper from a state standpoint, we're 20.7 in 2016, 18.7% in 2017, and then a bit of a spike back up, 19.6 in 2018. For Mount Carmel West, that houses a little over 200 beds, we've steadily decreased our mortality rate from 22.4% in 2016 to 16.9% last year. After reviewing this adult data, we found that physician nursing awareness of sepsis, whether it be through simulation, understanding coding a little more, also building up our EHR with screening tools may have contributed to this improvement in mortality rate. And here, taking a look, you can see that present versus non-present on admission for our organization, which is also highlighted in OHA data as well as Sepsis Alliance. And just like your data likely shows, the non-present on admission proves where we have opportunity for improvement. Unfortunately, those folks don't come in with sepsis stamped on their forehead. One avenue we all may want to entertain is building up that awareness and that knowledge-based skills to develop these autopilot type modes and skill-based performances in our healthcare providers. So as I go through the simulation, if it's something you'd like to repeat back in your organization, I'd like to share the 21 pages of goodness from the University of Southern California Medical Center. The format is beautifully laid out in this article, and you can adopt that scenario and tweak it as needed to fit your organization's needs. So now let's talk a little bit about the actual simulation. So here we used 1-week-old Matthew, who was brought in by his mother, who'd been partying all night, woke up with her baby being blue. And this is not an uncommon scenario for the community that we serve. School-aged cousins had been over the last couple of days who had coughs and runny noses, and you can see some initial vital signs here. This was some more information that we provided to the sim that included Matthew's weight and his initial assessment. And before we even started the performance, the simulation, we pre-briefed. As Stephen Covey says from that wonderful book, 7 Habits of Highly Effective People, always begin with the end in mind. Let's do that for our adult learners too. I feel the beauty of simulated education comes during that pre-brief and the debrief, not the actual simulation itself. So the pre-brief allows that platform for early engagement. Remember that second principle of adult learning I had a few slides ago? That need to be self-directed and autonomous, because you only know what you know. But if we do some pre-briefing ahead of time to show you the tools and resources you've got, you can then interact with them during the simulation. So when that real life emergency happens, hopefully we'll kick into that skill-based performance and autopilot mode, and the colleague will say, yes, I've been here before. So during the pre-brief, you can see a still shot here. We have a wonderful AV team. They help set up GoPros in the ceilings. You can see Justin over in the right side of your screen there holding a GoPro as he goes around during the simulation, pre-brief and debrief. So we do a lay of the land. We talk about vital signs, talking about knowing your resources, and all of the other equipment and resources that we have in the department. And with critical actions, success depends on previous preparation, and without, there's sure to be failure. So as we progress through the simulation, there's multiple critical actions that should take place as that scenario unfolds. As a facilitator, or if you're new to simulation, having these plotted out ahead of time are going to assist you big time down the road with pre-brief as well as the debrief. So from the ED standpoint, you want to know that that's my wheelhouse, we talk about appropriate triage acuity, making sure nursing notifies the provider, process issues. We also talk about other forms of access like IO lines that can be considered access, adults or pediatrics. And then problem solving. So we talk about if you can't get antibiotics and give them at the same time with fluids, what do you do first? So stimulating that conversation. And now, drum roll, the performance. So here comes Mom, who walks in from the surrounding community. She comes running into the emergency department just a little bit before 8. She comes into the lobby, she's frantic, yelling her baby isn't breathing, and the triage staff kick into action. The staff bring Mom and baby back to our trauma resuscitation bay to initiate care. We also include as many of our ancillary support as possible that Jim mentioned at the beginning of the webinar today. So here in the lower right corner of your screen, you can see that our chaplain is comforting our distraught mother, because while we're focusing on sepsis, and in this case pediatrics, we always want to remember that we're taking care of people, families, loved ones, and we want to try to make this as real as possible. So everyone's gathering the story, trying to figure out why baby Matthew is so sick. And here you can see baby Matthew is starting to decline. Our physician respiratory therapy are now bedside. We see colleagues using the Broslow tape. And I have to give a shout out to our physician in the simulation here, Dr. Brian Kelly, who also serves as our medical director, continually kept asking everyone in the room, what do you think our next steps should be? Again, involving everyone in the simulation. He would calmly review vital signs, ask for differential diagnoses, and elicit responses for next steps for the care of baby Matthew from everyone in the room. We take our time during these simulations because sepsis, as we all know, can be really difficult to recognize in any patient population. Tachycardia, poor cap refill, it should be taken seriously. We definitely want a rapid fluid administration recommended by patients for septic shock and PEDS patients. We can't often do that by gravity, so we talk about push-pull method or pressure bag. Speaking of medication, so after reviewing the story for Mom, looking at our SIRS criteria, it was identified that Matthew was in fact sepsis, and we ordered some broad-spectrum antibiotics. In this case, ampicillin and gentamicin. Not having these readily available in our adult ED, our pharmacist actually went down to pharmacy to mix up these medications so we could all experience what that wait time and antibiotic reconstitution truly feels like. As baby Matthew continues to decline, we prepare for intubation, utilizing the glide scope, and in the background, which makes me so happy, you can see that other members of the team are continually reviewing the pediatric neonatal doses, looking at Broslow tape. We're fortunate to have respiratory therapy in all of our freestandings, and it's definitely helpful to review their role with intubation, since in the emergency department, we are definitely a jack of all trades and masters of emergencies. Our therapists did a great job of talking through what they were doing as they were securing baby Matthew's airway. And then once baby Matthew was stabilized, Dr. Kelly talks to the transfer center so we can get him transferred over to children, to our content experts. Of course, the transfer center is notified ahead of time. I want to keep my friends in the transfer center. And so we notify them that we're facilitating a simulation that morning. The transfer center actually calls transport to see what the ETA would be in that moment, which in this case was 30 minutes. Also of note, we also involve our informatics department to create a fake patient in our EHR, so to make it as real life as possible. So it involves our unit coordinators in the transfer center. And so with that, we continue to monitor baby Matthew until transport arrives. And that concluded the physical part of the simulation, and this is where really all that magic happens, the key to capitalizing on learning. We review those critical action steps, and we're also being repetitive. We identify gaps in processes in a safe environment. Colleagues ask questions, we learn from each other, and that journey to reducing mortality rates continues. And everyone's goal, no matter what organization you work with, is to close that quality chasm. So during the debrief, you can see here our NICU and ED pharmacists reviewing differences in neonatal versus pediatric crash cards, because there is a difference. Respiratory therapy highlights their monitoring equipment on the baby warmer, how to safely prepare for intubation, because as we care for these folks, whether adult or pediatric, reviewing the emergency care of the septic patient can also bring a calmness and a clarity for future patient cases to see through that chaos to identify the patient as septic. As a bonus, aside from sepsis and pediatrics, our L&D educator, Amy, also reviewed labor and delivery equipment we have in our ED. So we had wins all the way around. So many of you may be saying, okay, what's next, Michelle? This all sounds great, but I don't have a simulation center. I don't have the AV support. How can I do something like this? I would challenge you to use case studies, pull real patients from your organizations to make it more meaningful, put a name and a face to sepsis. Use innovative ways to keep that awareness alive and well in regards to sepsis. Post those infographics from Sepsis Alliance. Use technology to help you educate, like Sepsis or Kahoot. And you may be asking, well, Sepsis Kahoot, what the heck is that? Well, I'll tell you. Kahoot is a free interactive quiz game. It's easy to use, it's colorful, it's engaging for any audience member. So you just go to kahoot.com, create a quick little profile, and away you go. Also, we have another resource. You have another resource at your fingertips, Sepsis. It's a free educational tool developed by Stanford School of Medicine. And I want to do a quick demo so you guys can see it. So you're going to go to the website listed here. You're going to click to play, and voila, Ron and Will appear on your screen. The program will give you the physical exam of the patient, and you have to choose your next step at the bottom of the screen. So in this case, you can read that Will is pretty anxious. He looks like they say he's in respiratory distress and starting to show me signs of shock. So I chose to give him a treatment with a bolus. And then you can see here that Dr. Sepsis gave me some accolades reinforcing that fluids should be given and giving me some more motivation, adult learning, that sixth principle for self-esteem building and goal attainment. And in the end, our patients win, because in sepsis, we all know that awareness and early recognition is what saves lives. And then it'll continue to, the game will continue to play. So as you choose the right plan of care for your Ron or Will, they'll continue to move up on the screen for you. So thank you for taking time to talk all things sepsis, adult learning, a little mix of pediatrics in there as well, and happy staging to everyone.
Well, thank you, Michelle, for a very detailed presentation filled with a lot of considerations for the various disciplines. At this time, I would invite all of our participants to submit any questions that you may have through our chat box feature. We do have several that have come in so far, so I'll go ahead and begin those, but please feel free to continue to submit questions if you have them. The first question is, and this is one that we've had in other presentations, how do you get your physicians engaged?
I think starting with showing them a story and also showing them the metrics, because there's always opportunity for improvement. Physicians, just like any other clinician, nobody wants to do a bad job, and we don't want to cause any harm to these patients. So I think engaging them in those quality metrics is one of the key starts.
Thank you. The next question is, how long does an entire simulation take?
So from some of the pictures and the talking, it may seem like it takes a lot. It's really just a lot of background work beforehand that I feel where the true labor is. But the actual simulation itself runs about 15 minutes or so. It's that pre-brief and that debrief afterwards. So start to finish with the pre and the debrief, maybe an hour, but the simulation itself truly only about 10 to 15 minutes.
Okay, thank you. The next question is there a fee for Sepsis, or is it necessary to set up an account?
Ooh, great question. It is completely free. All you have to do is click on that link and you are ready to go.
The next question that came in is, can you send the websites listed to participants? And I can answer that. We will have all of these slides from today's presentations posted to our website. And so you'll be able to have access to all of the information presented, the case scenario, the actions, and the websites as well. So just so you're aware of that. The next question is, how often do you recommend that these simulations should be performed?
Another great question. So there's not a lot of literature out there supporting that biweekly, quarterly, annually. So I'd say to gauge your department, I try to do a simulation 1 to 2 a quarter. Now, whether that's specifically with sepsis or, like you mentioned earlier, mock arrests of some sort of nature, but anything to get people out there and stimulated in their real environments. The more that you can bring it, if you do have high fidelity mannequins, to do them in the actual department so they can see, feel, and look at their equipment that's physically in their department. So for our success rate here with all things simulation, we do about 2 a quarter.
And do you rotate them by shift? Maybe you already mentioned that, but how is it rotated as far as time of day?
Yeah, so from a logistical standpoint, being a clinical educator, I've done them on weekends, in the middle of the night, the wee hours of the morning and the afternoon. I find that sweet spot is going to be between those hours of 6 to 9 a.m. So if you're in a hospital setting, you'd capture day shift and night shift. They're already staffing, and then come in for more better equipment as well as people coming in on their days off. And typically volumes aren't as high during those times.
Okay, thank you. The next question that came in is similar. How often do you perform the simulation? But also, did you receive any pushback from nursing or physicians to start doing more simulations? If so, what were your next steps?
So fortunately, just having that collaborative approach and getting everybody's buy-in and discussions beforehand, before pushing this out, I think that's the key. Because just like when you roll anything out new in your department, it's all about creating those change agents. So you have those champions in your department. Same thing with simulation, because I don't want people kicking their feet. Oh, they got another simulation that's going on. Also, I find a lot of success because I don't do unannounced. So maybe the week before, I will send out a couple random articles, or in this case, the pediatrics. So I'll pull up NRP algorithms and send those out to folks, to our staff. Review it in huddles and just say, hey, just be thinking about what would you do if a sick baby came in here, you know, a 1 month or a 6 month old. Be thinking about the steps you would be taking. We're going to be holding a simulation next week sometime. And then the day before and the day of, just going into a little bit more detail. So there's a lot of that pre-work beforehand to set the stage for the success in learning with that. And I find the unannounced piece of things, people enjoy that. And if you go back to all things adult learning, we don't like to necessarily be taken by surprise because we're egocentric and we want to show that, yes, I can do this on my own.
The next question that came in is, what happens during a simulation when an incorrect action is taken or when one is missed altogether?
So that is case dependent on the simulation. So I like to have those critical actions laid out. These are the heavy hitters that I want to make sure get hit. So if we miss one of those major critical actions, typically we'll pause during that moment. Did we miss a step? Is there something else you guys would have thought before leaving baby Matthew out front in the triage lobby to get some vital signs? Doesn't he look sick enough that you would have assigned him an ESI2 and brought him straight back to the resuscitation bay to have the provider look at them quickly? If they're not on that set of critical actions or high on my priority list, then definitely during that debrief moment is where we'll cover that. But it's never a punitive moment.
Thank you, and I think that's a really important point to make, that that it's a safe kind of environment to learn and not to be, not a place of shame or, but that it's for edification. The next question that came in is, have you given any thought to making simulation for sepsis mandatory, like CPR or advanced cardiac life support might be in an emergency department?
Sure, so I can speak from the emergency department standpoint. So the ED educators, we have all collaborated and we created what we call the ED core curriculum classes. A lot of the content adopted from the Emergency Nurses Association, and we're pretty proud. But during one of the classes, which we, interestingly enough, coined Three's Company, because we cover 3 major topics. We cover stroke, sepsis, and kids. So while there are 3 different, and precipitous births, basically. So that's why we called it Three's Company. So we cover these 3 major topics from an ED standpoint. What would you do in these situations? We also run simulations. Our amazing sepsis coordinator has committed to come to every single class, and she does about an hour presentation. They pulled 2 different case studies where one is more of an asthmatic whose source criteria gets triggered, but there's no source of infection, so that patient's not truly septic. And then there's another patient who does meet CIRS criteria who is a septic patient. So we talk through those scenarios, and not just because the EHR has you fill out this sepsis screening tool and you're just clicking. We don't want pencil pushers in the department. We want those critical thinkers. So doing those two different case studies and having her time and also a face to that, and then she's got all of those sepsis metrics because that's what she deals with every day. So having that regurgitated out to those ED nurses is very helpful. So in a way we do, because everybody has to go through that from an orientation standpoint. Ongoing, these simulations happen all year long, so not mandatory at that point.
Thank you. Our next question is, what have you found to be the biggest gap in knowledge for sepsis care to be from running these simulations?
Honestly, what we do from an educational standpoint to where we come clinically. So reaching out to other programs, and this isn't to say anything poor by any chance of what we're feeding to our providers and to our nursing staff or to our nursing students, but even through school, there's not a lot of sepsis simulation happening. I think it may be a lecture piece of it, so that more didactic learning, which again, adult learners don't flourish in that, and what are residents and nursing students, adult learners. So I think our opportunity and our gap is starting it sooner rather than later, not waiting till we're licensed clinicians to interject this education and simulation.
Thank you so much. Those are all of the questions that we've received so far. Thank you again for this wonderful presentation, and thank all of you on the line for joining us today. And as a reminder, we will have our next webcast on February 20th, where at that point we'll be reviewing our statewide initiative data. That call will not be recorded because it will include data. But again, we ask you to join us on Wednesday, February 20th, 11:30 a.m. Eastern Standard Time. This concludes today's call, and we hope you have a great day.